All right. Well, I think we'll make a start. We've got to 40, so that's good. So welcome everybody, and thanks very much for attending this webinar. So it's hosted by the Health Services Research Association of Australia and New Zealand. This association has been going since 1999. Was that the first meeting, Jackie?
More or less. It was set up in 2001 following the 1999 conference.
Yeah.
Yes.
And we've got a rejigged website. It's got a lot of information on it, but we thought whilst the definitions that we provide on the website are useful, I think it would be good both for people who've not got any experience in health services research who might be interested in what it's all about, but also people who work in particular areas of health services research might be interested to kind of learn more about the full scope of what health services research is about. So that's really the rationale for putting this webinar together, and it will go onto the website as a resource for anyone who's wanting to look for educational materials to introduce people to health services research. So I talked about definitions. Now I'm trying to control my slides. There we go. So just a couple of introductory slides. So what is health services? I forgot to put a question mark there. What is health services research? Well, the way I think about it comes back to the familiar mantra, really, of the right care at the right time in the right place. And you can see there that I've added a couple of more rights, so by the right person in the right way. And so at a very broad level, that's really what health services research is trying to support, is the provision of that mantra. And the two very broad ways in which we try and achieve that or support that objective is directly through informing implementation of the right practice, but also more indirectly through informing health systems policy with the aim of putting the appropriate structures in place, but also incentives at an individual, clinician, patient level, but also at an institutional level as well. And so we'll talk about those two broad roles in this webinar today. And then in terms of actually applying the research, I mean, I kind of think of it as a pretty simple approach in theory. In practice, obviously, it's not quite so simple, but you start by identifying or generating evidence to inform what should be done, and then if the evidence is sufficient to support implementation or to support or inform policy, you implement the changes in practice or the policy associated with that evidence, evaluate the impact, and then repeat. So it sounds pretty straightforward, but in practice, obviously, it can be quite difficult. So we'll get on to the contents of today's webinar. So we've got four speakers who are going to talk about different elements of health services research. The first part of the webinar is going to focus on what we defined as health services research in practice. So that's kind of implementation side of things. And Catherine Harding, who's a senior research fellow in the Allied Health Clinical Research Office at Eastern Health in Victoria, is going to lead that first section, but she was supported by Tilly Payne and Laura Wilkinson, who are also on the executive committee of the association, putting her slides together. Then I'll talk a little bit about, I'll provide some examples of health services research in relation to informing health system policy to improve hospital performance, and then pass on to Suzanne Robinson, who's our WA representative on the exec committee. And she's done a lot of work around commissioning, particularly in primary healthcare setting. And then we'll finish with Jackie Cumming, who is our previous president. For 7 years was president of the association. And it's great that she's still very strongly involved with the association and the executive committee. And she'll talk about health service research at a broader level, at a policy level in terms of national strategies. And then we'll finish with some questions and discussion. And so, unfortunately, it's not possible to let everyone speak. There's now 56 of us online. So what we use is the Q&A button. You can see a Q&A button in your Zoom controls. So at any point throughout the talk, if you think of a question or a point of discussion, please just jot it down in the Q&A section, and then I'll save all the questions until the end, but we'll have I'll basically relay the questions to the panel, and we'll hopefully have a good discussion there at the end. So at that point, I'll pass on to Catherine, who's going to talk about health services research in practice.
Thanks, John, and thanks very much for the opportunity to talk today. This has been really great putting this webinar together. My talk is really going to focus begin at the local level about what clinicians can do in terms of health services research within clinical settings. My own role is with the Allied Health Clinical Research Office here at Eastern Health, which is a large metropolitan health network in Victoria. My role is really about promoting and supporting and doing research within the health service, particularly focused on allied health services, but we certainly work in a very multidisciplinary sense. So, a wide variety of research designs can be applied to health services research questions. And in my talk today, I'm going to go through a few different designs, some of which might be often associated with other types of research questions, but can certainly be used to answer questions around delivery of health services. A lot of clinician researchers might be doing health services research, but they don't necessarily identify it as such. So we see this a lot, particularly within allied health. Any of the physios and OTs and speech therapists that we work with, they're often doing projects that are about health service delivery, but they kind of still think of it as a physio question or an OT question. So, part of this is about thinking about questions from different angles and about what benefit you can get by thinking of something from a health services research perspective. And I guess another aspect of this is that service delivery questions, from my observations, are often tackled with quality or redesign approaches. And there's nothing wrong with those approaches. They all, have an important role to play. But this is just about recognising that you can also approach these questions with rigorous research methodology, which does allow us to answer some questions sometimes in a more rigorous way, and just to be able to determine with less bias about whether the outcomes that you get from a project can be attributed to the interventions. So if we can go to the next slide, John, the first, yep, that's it. So first I'm just going to talk about a couple of randomised controlled trials that we've done around health services research questions, or that have been done at our health service. I shouldn't take all the credit for this first one. I wasn't directly involved, but my colleagues were. So, randomised controlled trials are, often considered, associated with very much with interventions and drug trials and things like that. But there's certainly no reasons that we can't apply these kind of methodologies to health services research questions at the clinical level. So this one was about evaluating the effectiveness of a 6-day versus a 5-day per week allied health service in rehabilitation. So this is led by Nick Taylor. I realise I should have Nick's name on this slide, and I think that's something with all of these slides. But this RCT involved 900 patients receiving inpatient rehab, and they were randomised to receive therapy on Saturday or their usual Monday to Friday rehabilitation. They looked at length of stay. They looked at length of stay, functional outcomes, readmissions, and also did a health economics analysis, including 12-month follow-up. And that RCT was able to show that a 6-day service reduced length of stay by 2 days, and patients had better functional outcomes and reduced costs. So by setting this up in a really rigorous way using an RCT, we were able to get some really solid evidence about the best ways to set up rehabilitation services. Skipping to the next slide, John, the next RCT is a much smaller level. That previous slide, previous project was a large NHMRC funded trial. This was a much smaller local-led project within our health service, but also applying that same kind of method. And this was about SMS reminders and failure to attend rates in outpatient physiotherapy. And although it was conducted in a physiotherapy service, the findings were very applicable to other services as well. So the question came up about whether it was helpful to send out SMS reminders in a service that had a reasonably high failure to attend rate. 679 patients were randomised to either receive an SMS reminder or not. 11% of the patients in the SMS group failed to attend their appointments, but that was compared to 16% in the control group. And what it particularly told us is that patients who received the SMS group, if they weren't planning to attend their appointment, they would tell us. So what it really meant was that those appointments could be rebooked. So it didn't necessarily mean that more patients attended their appointments than did before, but we knew if they weren't going to show up. And so you could make better use of the available services and resources. So, it showed that it can be an effective way to reduce non-attendance and make better use of health service resources. And again, rather than just putting something in place saying, let's give an SMS reminders a go, using health services research sort of framework and a more rigorous method really tells us that this is something that is worth investing in and something that we should be doing. Moving on to the next slide. Oh, sorry, can you just click a couple of times, John? I've obviously got some, yeah, just keep clicking through, that's fine. Yeah, that's it. So this is a control before and after trial. Before and after data is often collected as part of quality projects and smaller scale research projects. And as I'm sure you'll be aware, it's often a bit subject to bias. It can be hard to tell whether the outcomes that were achieved were really due to, how much they can be attributed to the intervention. One way of just adding a little bit more rigour to a before and after trial is by adding a control group. So looking at the diagram there showing the research method, we had 2 sites here receiving usual care. This was an intervention looking at a new model of access and triage to see if it could reduce waiting time for a community rehab program without adversely impacting on other aspects of patient care. So we had 2 sites within this large health service that each ran in a similar way, similar management, similar patient groups, one slightly smaller than the other. They both ran using usual care for a 6-month period. We then introduced the new model at one site while continuing to collect data from the other site. And we're then able to compare site 1 pre to post, but we could also compare the intervention site with the control site. And we found that waiting times in the post-intervention period at the intervention site reduced by 40% without any adverse impact on other aspects of service delivery or patient care, and there weren't any significant changes at the control site. So that just adding that extra element to the research design gives us a lot more confidence that the change in the model of care was responsible for those reductions in waiting time and not something else that was going on at the service at the same time. Moving on to the next slide. Okay, so this one is a stepped wedge randomised control trial. This is a little bit more complex trial design. This is an NHMRC funded trial, so it's a much larger scale, but it grew out of that work from the previous slide where we were able to collect pilot data from the smaller control before and after trial. So based on that, we were then able to get a much larger grant to look at this same intervention to reduce waiting time and see if it could be applied on a large scale across a broader range of health services. So we had eight different services involved in this trial. You can see that site number 1 to 8 down the left side of the block there. And then along the top, the numbers along the top represent 4-week blocks. So the intervention, everybody had a period of pre-intervention data collection. The sites are put in random order, and we progressively introduced the intervention at each site. So, and then collected a period of post-intervention data afterwards, and it's then statistically possible to compare all the pre-intervention data across all the sites, with the post-intervention data at all sites, controlling for the differences between services. So that the cluster step wedge randomised control trial is becoming more popular in health services research. It's quite attractive to service managers in particular because all of the services get the intervention in the end. And there's also a bit less potential for contamination, which can be a bit of a problem in regular cluster randomised controlled trials where some of those in the intervention group might influence a little bit some of the people in the control group, particularly with service level interventions. And we were able to, we've been able to find from this trial that from this trial, we've been able to see that the intervention that was successful in a single service in the previous control before and after trial has actually been able to reduce wait times on a much broader scale with a more diverse range of services. Okay, so moving on to the next one. Just a couple of words on qualitative methods in health service research. So the qualitative health service research can be really useful in clinical settings, particularly for smaller scale projects where there's perhaps more limited number of patients, or they're running something like a large cluster randomised controlled trial, or even a regular RCT is difficult. So this was one example, again around waiting time. You can see a little bit of a theme to my work here. But so this project aimed to explore managers' perceptions of factors that affect waiting times in ambulatory services. We were really interested to know, well, what did the managers think about why their services had long wait times. There were semi-structured interviews with 26 service managers and senior clinicians, and the results were really interesting. Some things were very predictable. Of course, nearly everybody said, well, the reason we have long waiting lists is because we have high demand and we have insufficient resources. But we also found that there are a whole range of modifiable factors that that people come out with that were quite consistent across the various interviews. So things around inefficiencies in the way that referrals are processed, and the need for duplication at various stages, and non-attendance rates and things like that. So there were a whole lot of things that came out that could be changed, and I think one of the things that has been a factor in success in some of our previous trials is addressing a lot of those little things. We think it can reduce waiting times by 30 to 40%. Okay, and I think we have one more example. Something's gone a little bit funny with the slide in the top corner there, but this was just a retrospective cohort study using an audit of medical records. This is a great example of an individual clinician level project, which could be seen, this is from a speech pathologist, it could easily be seen as a speech pathology project and look sort of seen with a speech pathology lens. But I think when you look at it from a health services research perspective, you get quite a different story. So the aim of this project was just to find out whether there's a relationship between communication difficulties and falls in stroke patients. So this particular clinician had observed a number of her patients with severe communication difficulties having falls while on the ward, and wondered if there was a relationship. She did a simple audit of 100 medical histories, and she collected a whole lot of variables around presence of a communication disorder, falls on the ward, and a whole lot of other demographic variables. And what she found was that the patients with communication disorders were twice as likely to have a fall while they're in hospital. And she also found that this was more predictive of falls than the score on our organisation's mandatory falls risk assessment tool. I think these sorts of falls risk assessment tools are probably familiar to a lot of people in the audience. And when you consider this project from a health services research perspective, I think it's really interesting to think that the health service are putting a lot of time and resources into assessing falls risk to try and reduce what's a really big problem in hospital settings. But yet the effort that's going into making sure that people comply with the requirements to assess falls risk using this particular tool may not actually be a good predictor of risk, particularly in this population. So by thinking from that perspective, it changes perhaps how we think about how we're going to disseminate the results of this study. Is it something that goes to a speech pathology journal, or is it actually something that goes to something with a much broader audience, which may be more about reaching health service managers about how we predict falls, and whether the one-size-fits-all falls risk assessment tool is actually meeting the needs of services and patients when it comes to this really important issue. Final slide, John. Sorry. Yeah, so just a few questions to ponder really based on some of those examples. So, you know, a lot of clinicians I think have research questions in mind that could be considered health services research, or maybe people are already doing health services research, but you know, why does it matter? Why does it matter if you call your project a physiotherapy project, or a, you know, a stroke project, or a health services research project? Well, I think it actually does have a number of benefits. So, you know, one thing is to it kind of broadens your horizons in terms of where you look for opportunities. You know, perhaps giving access to different types of funding by looking at, you know, in the funding categories that might be around health services research, or organisations that are willing to fund that type of research. It might be about reaching new audiences, and I think that previous example is a good one. It's about, you know, not putting a project like that into a discipline journal, but thinking about where else might there be an audience for it, and thinking about who else needs to know about it. It's not just speech pathologists and physiotherapists in that particular example. It's the people who are making the decisions about which falls risk tools we should be using within organisations. Some of it may be about fostering new collaborations and thinking about whether you know, there's value in seeking out a health economist, or you know, somebody else that you might not be might not normally consider working with, to look at your questions from a new angle. Yeah, and it's about considering problems from new angles, about cost effectiveness and safety and feasibility. Identifying that an intervention, you know, works or doesn't work is not necessarily enough to get that message translated into practice. We also need to know whether it's practical to implement that intervention into a clinical setting. Is it going to be cost effective? You know, is it going to be feasible? So those sorts of questions, you know, are really important, and particularly knowing how tough it is to get things translated into practice. So I think that my intention has really been just to give a bit of a summary through a series of examples about how health service questions can be answered, you know, using health service research methods within clinical settings. And it's not something that has to, the speakers to follow are going to talk about things that are a lot more big picture. But, you know, I think, you know, clinicians even at very local levels can be thinking about health service research and how things can be viewed with this kind of a lens to get more benefit out of the work that we're doing in health services. Thank you. I'll pass back to you, John.
Thanks, Catherine. That was yeah, some fascinating examples, and clearly everyone's very busy down at Eastern Health. So that was, like I say, or like Catherine said, that was a focus on HSRAANZ practice, and now we're going to move to a broader level and talk a little bit about policy. So I'm going to give a few examples around how health services research can interact with and inform policies around hospitals, and then we'll move into primary care. So the three kind of linked examples I'm going to talk about are all the same objective of improving hospital performance, but slightly different approaches. So how do we evaluate the effectiveness of service reconfigurations with a view to informing continuous improvement where required? Funding models, that's a really key area of policy with respect to hospital performance. And then finish with a little bit of a discussion around patient-reported outcomes or patient-reported outcome measures, which I'm sure everyone has heard a lot about, and we're really just waiting to see what impact they're going to have, if any. So the example I'm going to use for service reconfiguration evaluation is actually from England, but it's a really nice example of what you can do with health systems data to look at the impact of big changes in the provision of hospital services. So this was a natural experiment, really, in that there were decisions made to reconfigure the delivery of stroke services in two areas of England, so in Greater Manchester and in London at around the same time. So here we're describing the configuration prior on the left-hand side. So you have a stroke, you go to your local ED, you're then admitted to an acute stroke unit or even a non-stroke ward, and then following that you have rehab services in the community. And we can see the difference in the reconfiguration. So in Manchester, depending on when you present, so if you present in less than 4 hours of onset of symptoms, you get referred to a comprehensive stroke centre or a primary stroke centre. If you're over 4 hours, you go to a district stroke centre, receive the appropriate care at those locations, and then on to rehab. In London, everyone goes to a hyperacute stroke unit, and then maybe down transferred depending on diagnosis. But in terms of the evaluation, they use what was called a difference in differences approach, and these figures illustrate the effects of the different reconfigurations quite nicely. So you've got 4 outcomes, so mortality at different days, 3 days, 30 days, 90 days post-admission. And what these figures are showing are the change in those outcomes over time. So the blue line is the rest of England, so outside of Manchester and London. The red line is what happened in Manchester, and the green line is what happened in London. And for some reason, they've switched the colours for the time of reconfiguration. So the red vertical line is the timing of reconfiguration in Manchester, which links with the green vertical line, horizontal line, and the green is the London. And so you can see that over time, mortality was decreasing in the rest of England, and it continued to do so in London and Manchester. And as you kind of go out to 90 days, you can see the impact was increasing. Length of stay also was decreasing over time. So it really just emphasises the need for a control, because if you'd have just looked at Manchester and London on their own, you say, well, that's great, it's looking good. But because we can look at the rest of England at the same time, we can see, well, actually, there was a general improvement over time. So we need to control for that improvement over time. And so when you actually look at the statistics, compared to the rest of England, we can see that the reconfiguration in London resulted in a significant reduction in mortality at all of those time points. Whereas in Manchester, there was no impact on mortality compared to that background improvement in outcomes. Whereas for length of stay and costs, there were significant reductions at both locations. So that type of evaluation, just using health systems data, they didn't have to go out and collect any new data, provides real insight into the impact of those alternative reconfigurations. Looking at funding mechanisms next, activity-based funding is taking over the world, it seems. Certainly in Australia, with the Independent Hospital Pricing Authority controlling or implementing activity-based funding at a national level, it is now relevant in all states and territories. So the basic objective is that the hospitals receive funding for the activity that they produce, and that funding reflects the expected costs of delivering care. So the idea is that if you're delivering care at above expected costs, you've got an incentive to reduce costs, because you're not, you're essentially losing money. But in terms of the evaluation of activity-based funding, there's been a reasonable amount of before and after type studies looking at the impact, and they find that we get increased activity because there's an incentive to do more, because you're getting paid for every additional patient you treat. There's a reduced length of stay, which you'd also expect, and combined, there's a reduced rate of growth in hospital expenditure. But the big question really is, what's the effect on patient outcomes? So we've got this incentive to reduce costs, but what's happening with respect to outcomes? And that's really an area that's not been a whole lot of research on, but with the advent of linked data, we can now look at outcomes beyond discharge. So previously, we really had to focus on inpatient mortality, but now we can go beyond discharge and look at readmissions, or related readmissions and mortality in a time period beyond discharge. And so we looked in South Australia at chest pain patients, And so here we're looking at outcomes, mortality within 90 days and related admissions within 90 days. So we've defined our base case hospital, hospital 1. We can see the proportions, so 1.2% of patients dying within 90 days. And then we've got the odds ratios compared to hospital 1. So we can see hospitals 2 and 4 have got a lower mortality than hospital 1. Not statistically significant, so these are the confidence intervals. You can see they cross 1. But hospital 3, maybe we want to look at in a bit more detail, because they've got almost, well, more than double the mortality rate at 90 days, and that's statistically significant. So that provides an indicator of what we might look at as a consequence of of hospital performance, but linking back to activity-based funding. And likewise with admissions, we can see here that all 3 of the hospitals have got increased rates of admissions compared to hospital 1, but hospital 4 in this case has got a statistically significant increase in admissions. So it's really giving us a bit more of an insight into potentially important outcomes that we can investigate further. And we certainly wouldn't recommend taking drastic actions based on these results, but it's really a kind of screen to say, well, which hospitals might we want to look at in a bit more detail. That was South Australia, where we've got relatively few hospitals to look at. This is just an indication of what's going on in New South Wales. So the Bureau of Health Information are doing a lot of really interesting work. And this is a nice way of presenting similar data. So it's looking at expected and observed mortality rates following admissions for stroke. And you can see that the dotted red line is the 95% confidence interval, upper confidence interval. So hospitals that are above that line, it's an indication that their mortality rate is significantly higher than would be expected for a hospital of their size. And below the green line is identifying hospitals that are really performing above expectations. So it's just another way of presenting similar data, but I mean, there's room for implementations. At this stage, we're really just illustrating these types of methods, but how they get used in practice is the next stage in this area of research. And then the third item I wanted to talk about was patient-reported outcomes, and this also relates to funding, because ultimately, and some people are certainly proposing this, that activity-based funding should account for patient-reported outcomes rather than just clinical outcomes. So patient-reported outcomes are where patients fill in surveys describing their quality of life or the symptoms associated with the condition that they're being treated for. And the best example of this, of the use of patient-reported outcome is in the English NHS, where they've been collecting pre and post PROMS data for these 4 conditions. And this paper, published in 2014, they started in 2009, showed how things were progressing over time. So in the first 3 years of implementation, just taking hernia repair as an example, using the generic patient-reported outcome, we can see that there's exactly no difference in PROMS post-discharge across those 3 years. So that's a bit disappointing, because the idea is that by collecting the PROMS data, you're going to incentivize hospitals who are maybe getting worse patient-reported outcomes to improve their performance, and you'll see a general increase in PROMS over time, but that clearly wasn't the case. So a study in Ireland actually took it one step further and took direct action to feed back PROMS data to individual surgeons. So this was a randomized controlled trial of 21 orthopedic surgeons, half of whom received peer benchmarked feedback on the patient-reported outcomes of their patients with some education. But again, no impact was identified. And I think there are some reasons for that in this particular trial. So there wasn't a huge amount of time provided for the surgeons to improve their performance based on the feedback of the proms, but also there wasn't much variation at baseline, or there wasn't a whole amount of detail in the paper, but it certainly implied that there was a similar range of prom scores across surgeons. So you just kind of wonder whether there was really much of an incentive to improve if there wasn't that much variation at baseline. So the evidence to date is not too promising in terms of the potential for patient-reported outcome measures to improve hospital performance. But I think it really just provides a foundation for looking harder for how proms should be used. So I think there's a bit of a feeling that proms is a good thing that we should be doing, but I think the evidence to date suggests that we really need to think and investigate methods for using proms to improve hospital performance. So it'd be interesting to see how that progresses in the coming years. So that was the examples that I was going to talk about. So I'm now going to pass on to Jackie. I think it was meant to be Suzanne. Sorry, but is that okay, Jackie? We'll go to you.
Yep, that's fine.
Yes.
Okay, thanks. So I'm going to talk about a national strategy that we were involved in evaluating. This is back in the 2000s. So John, the next slide, please. Great, thanks. So in 2001, the New Zealand government introduced a new primary healthcare strategy that had a vision of people being part of a local primary healthcare service that improves their health, keeps them well, easy to get to, and coordinates their ongoing care. And services will focus on better health for a population and actively work to reduce health inequalities between different groups. Next slide, John. Great. This was quite a complex strategy that did a number of different things all at once, which then poses all sorts of challenges for evaluation. And also one of the key issues with this is that it introduced all these changes across the country all at the same time. So you're not able to have some pilot programs and look at the impacts of those. You're having to evaluate a program that's been introduced across the whole country kind of all at once. And I'll talk about that in a few minutes. But some of the things that the strategy was doing was, first of all, was reducing barriers, particularly financial barriers for people in terms of accessing primary healthcare services. So as many people will know, in New Zealand traditionally there's been quite a high fee for seeing a general practitioner, and that fee had risen over time and was seen to be providing significant financial barriers, particularly for Māori Pacific groups and people with more health needs, lower income people, for example. So part of the strategy was to reduce financial barriers. Another change that was made was to support the development of what were called primary health organisations. And what was happening here was these were a new meso-level organisation introduced into New Zealand, building on some previous activity, but making all practices, general practices, having to join them. And what would happen was that individuals would enrol with a general practice, and that general practice would choose to belong to a particular primary health organisation. And these primary health organisations would actually support the development of primary health care. So they would organise all the money, all the backroom things that need to be done, but also start to develop services as well. Another key thing that the strategy was looking to do was that recognising that for many years New Zealand primary health care had been largely delivered by general practitioners, often working on their own, maybe with a practice nurse, but they're in small practices on their own. And so this was just part of the strategy, was actually trying to encourage multidisciplinary approaches to services and more decision making by teams as well. And there's also a desire to support the development of services by Māori and also by Pacific providers as well, who might better meet the needs of those communities. Next slide, John. Okay, so to support these particular changes, these are some of the things that actually then happened. So the first thing was that there was a significant amount of new money going into primary healthcare. About $2.2 billion was planned for about a 7 or 8 year period. That money was to go through primary health organisations down to general practices to enable those practices to reduce the fees that people pay when they use services. And the money was rolled out firstly to what were called access practices, which were serving higher needs communities, and then rolled out over time, sort of year on year, to different age groups in the other practices. And other funding was then introduced to extend services and also develop new services as well. We had the establishment of these not-for-profit primary health organisations that would sit over the top of general practices and help them develop services. And we also shifted from what was a targeted funding approach to a more universal funding. So prior to this, only some people in the population had access to government subsidies to help them access primary healthcare services. Now we were moving to a universal funding arrangement. And the funding formula also changed. So we moved from having fee-for-service for general practitioner services, so a general practitioner being paid every time someone went to see them, to capitation paid to primary health organisations and then paid on down to individual general practices. This promotes better equity by allocating resources based on need rather than just those who actually turn up at a general practice, and the funding formula was weighted by age, gender and ethnicity. So as you can see, a whole lot of changes there all going on at once. Next slide, John. Great. So where does health services research come into this? Well, one of the first things was that there was some international evidence on which this primary healthcare strategy was actually based. And I guess in New Zealand, there'd been quite a bit of work prior to the introduction of the strategy to sort of look at what are the different models of primary healthcare that we might have, what will happen if we do some of the changes that we've just kind of talked about. So there was some evidence that a strong primary healthcare system would support a lower cost, more equitable health system. The good evidence that if we had cheaper primary healthcare services, that will lead to an increase in use of services, particularly for lower income people. Some work that had been particularly done in the United Kingdom on the role that primary health organisations as meso-level organisations might play in some of the issues that they might actually face in terms of getting themselves established and building relationships with the general practices that they work with. And there was also some New Zealand evidence and some international evidence, but it was a bit unclear about whether the change to capitation on its own would actually lead to a broadening of the general practice workforce. In other words, will we get an increased role for nurses? Would other primary healthcare staff come into practices such as social workers, pharmacists and so on? And it was some New Zealand examples where that hadn't necessarily happened as a result of a change to capitation. Next slide, John. So one key thing with this is how are you actually going to evaluate it? As I said, you can't do a pilot and everything's kind of being rolled out across the whole country all at the same time. So our focus was really on a formative evaluation, exploring implementation, and then really a before and after design, which was actually then looking at key achievements. And of course you couldn't be sure that it was only the things that were actually changing as a result of the strategy that would be responsible for what was changing, but there was no other design that we could actually use for this. This particular project was funded by a mix of government organisations and our Independent Health Research Council, and so we were working directly with policymakers throughout the evaluation. And it was a large national team of researchers, so people in Wellington, Auckland, the South Island, working together from a range of different disciplines as well. We used a mix of methods, as is common in health services research, so reviewing key documents, strategy documents, plans, minutes of meetings, those kinds of things. A large number of key informed interviews across the country, again with policymakers, those working in primary health organisations, those working in practices. We did a survey of primary health organisations. At this point in time, there was more than 80 of them, so they were all rung up, and we did a kind of over the phone survey with them. We got a lot of information about the PHOs, and we also did a survey of practices as well. And then we had quantitative analyses, look at before and after of administrative data, which I'll talk about in a few minutes. We had really good participation overall in this evaluation. One of the key things was that the strategy was really well supported, and so people were keen to support the evaluation as well, so that was great. But we did face some key difficulties in doing this. First of all, we were unable to track the new expenditure over time. So although the government said it was going to spend $2.2 billion, we don't know whether they did. One of the key things is that there's no national primary healthcare data set in New Zealand, so there's nowhere to go to track fees information, what it is that people are actually paying when they see a GP, nor utilisation data either. So we had to work with a group that worked directly with a number of different practices, and they downloaded the data directly from the practices and then analysed it using before and after methods. We had to work very hard to get a good response rate from the general practice survey. This is an ongoing issue in primary healthcare research. You have to put a lot of time in getting people to actually complete the survey. And one of the key issues with this was that the evaluation actually didn't fund research with consumers. So we weren't able to kind of talk with consumers and say how were the changes in service delivery affecting them. Next slide, John. So just some key findings. This goes back now around 8 years or so, but some of the key things that we found, which are then important in a policy context. First of all, there was very strong support for the strategy, and of course strong support for having new funding going into primary healthcare. This was actually one of the first times since the 1930s, 1940s that primary healthcare had had so much attention paid to it. There was almost full enrolment, so almost all New Zealanders over a number of years ended up enrolled with a particular primary health organisation. There were large numbers of primary health organisations had developed. The government hadn't said there can only be so many, it just allowed as many of them as wanted to develop, so there were more than 80, and of course there was significant variance in their size and their makeup and their roles. And one of the key things that we were a little bit concerned about was that some of them only seemed to be post boxes for the funding, and that is that the money was just going straight through them down to general practices, and it was unclear what role they were actually then really playing in terms of developing primary healthcare services. And some concern about overlap between New Zealand's district health boards and these primary health organisations in terms of their roles. When it came to looking at consultation rates for primary healthcare services, they did initially increase as the new funding was rolled out and as the fees that people paid actually fell. This was a really complicated analysis to do because I talked about before there was that complex rollout of funding, and we had to break down the analyses into all those different groups in the population in terms of when they got new money that would allow the fees that they pay to fall. One key thing that we found was that the fees did not fall by as much as the new government money. So new money was going into primary healthcare and the fees were falling really only by about half as much as you might have expected. So the government might have expected to fall in fees of about $25 per visit, but they were only going down by about $12.50 on average. And that's because some of the money was then being kept in primary healthcare practices. The number and proportion of nursing services did increase significantly as well, so nurses began to play a much stronger role in primary healthcare service delivery. And then in terms of the other things that might be expected from these changes, there was actually little sign of them. So there was very little change in models of care. It was still very much focused on a 15-minute GP consultation, and the focus on integration wasn't really happening either, so integration with other primary healthcare services and hospital services and so on. Next slide, John. So just some reflections. I was thinking about this. We're about to start, we'll get involved in some new work potentially in this area, and I was just reflecting on the evaluation and also what we found. following all the work that we did, further changes were made in the sector. For example, primary health organisations were amalgamated, and there's now around 30 of them. And there was an increasing emphasis on integration. But there's actually been very little recent research, and we know very little now at the moment about the models of care that are actually out there, about integration, about roles and relationships. And still, there's almost no research still with consumers. So we really do not know how all of these changes over a 17-year period are actually affecting consumers and the services that they use. I think that's it. Or is there another slide? Great.
No, that's great. Thanks, Jackie. So we'll pass on to Suzanne.
Thanks, John, and thanks, colleagues. So staying in primary care then for a little while, I'm going to look at commissioning in primary care. So I'll give an overview of policy drivers around commissioning, then focus a little bit on what types of research. So not specific projects, although I will bring in a couple of examples. And then a little thought around impact on policy and practice, and also what that sort of impact means for health services research and how we might use that in terms of thinking about future funding or our own development as we go through our careers. So in terms of commissioning then, well, primary care-based commissioning, it's been a policy concept that's been around for over 20 years in jurisdictions such as the UK, and more recently in Australia through the primary health networks. Whilst there's no single definition of commissioning, at its simplest, commissioning is the process of planning, agreeing and monitoring services. However, securing services is much more complicated than securing other goods, and the complexity, diversity of the health sector and the services delivered is unparalleled to any other sector. So that makes it complicated for those doing the activity of commissioning, and makes it even more complicated for us as researchers when we want to look at commissioning activity. And I'll come back to that later. So commissioning is not just one action, but many. It ranges from health needs assessment for a population through the clinically based design of patient pathways to service specification, contract negotiation or procurement, with a continuous focus on quality assessment. I should say in the UK, it's been the main place for the commissioning activity. The UK commissioners currently hold around 60% of the NHS budget and used to hold about 80%. So in UK terms, it's big business. So then, what have been the policy drivers for commissioning? Whilst these have varied across countries, they do tend to relate to some common themes. They relate to pressures of increased demand and increased costs of healthcare, so the actual dollar that we put in and the demand that continues to increase. Focus on strengthening primary care and keeping people out of hospitals, and there's lots of discussion whether or not that would be a cheaper option, and there's the thought that it wouldn't, but actually it may be what patients want and will be better for communities. Increase the competition in primary care provision, so having a more market-based focus with a view of increasing efficiency and quality of services. A separation of provision of public service from commissioning of services. And there's an interest in investment and disinvestment decisions and cost effectiveness and value for money. And these are important, I think, as researchers, because what's the drivers for policy is often the drivers for the interest around the research. So governments will tend to fund studies that are focused around some of these areas. Likewise, local commissioners are also interested in funding activity and research that will demonstrate they've achieved some of this, or in fact, if they've not achieved it, why not, and what can they learn? So a real focus is on the right care, right time, right place, as John put it in his earlier slides. Next slide, John, please. Thanks. So if you think about the research into commissioning, there's been actually lots of it, and there's a few key authors or researchers that have been involved in that. Judith Smith recently spoke at our conference earlier this year. Or last year, sorry, and she did a lot of work in that area with colleagues such as Chris Ham, Nick Mays, and myself, Helen Dickinson. There's lots of research in this area, and that's been going on for some years. In terms of types then, there's been large-scale and small-scale evaluations that have been funded by governments. The local commissioners themselves have funded lots of activity. Universities have seed-funded money into this area. And then there's been large government-funded research, mainly from the UK, the National Institute for Health Research and its predecessor, SDO. So there's been some large grants funded that have really tried to look at the implementation and outcome of commissioning, particularly in the UK NHS. And there has been some studies in Australia that have been government-focused pieces of evaluation that have tried to look at primary health networks and their predecessors, Medicare locals, in terms of how well they're doing it in terms of the policy reform. And there's been studies from the broader policy perspective that have looked at the process, as I say, and shifting policy focus and what impact or success commissioners might be having on the key drivers. There's also been quite a focus on looking at some of the effectiveness and cost effectiveness of the commission services. So the services, that individual services that may have been commissioned by our primary health networks, for example, could be around older people services, child services, mental health. So there are some discrete projects that are not necessarily just about commissioning in its broadest sense, but are actually to help inform commissioning of services and programme development. My own work's involved exploring the effectiveness and cost effectiveness of commissioned interventions in primary care. It's often difficult to undertake such activity. It's hard for a number of reasons that I'll come on to unpick a little in the next couple of slides. Not just it's difficult, but also it's difficult to get the engagement of people to want to do that. So I say we'll come on to that later. Next slide then, John, please. So in terms of what the actual policy, the evidence says then, just before I move on to that, just be good to think about what are the types of research methods that have been used. And Jackie has outlined some of the qualitative sort of type studies, and that's what's tended to be used here. I mean, it does depend on the aims and objectives of the research, as it should, but the implementation and process evaluation type activity tends to use qualitative methodologies, case studies, interviews and observational studies. They've often been very much focused, not again, as Jackie mentioned, not really with consumers, but with the actual commissioners of services and the stakeholders involved in that. There's been a smaller number of quant studies. These are tended to be more survey-based and more descriptive stats rather than anything more sophisticated, and with a small number of mixed method studies. So that's the policy and process and implementation. In terms of what this type of work has found, we found that it's quite complex. So it's complex in terms of trying to untangle what's actually happening in commissioning. There's often overlaps, this policy overlaps with many other policies. And the commissioning is sporadic, it's irrational. So it's quite difficult to then impose some sort of rational research perspective onto the actual commissioning process. It's been important to have complementary policies and incentives that focus on efficiency, value for money, accountability and quality that could be used to engage and incentivise clinicians and providers. John mentioned activity-based funding, and that came up quite a lot in research, that's been very important to engage the hospitals, which is for the UK, services in the hospitals are commissioned by primary care. So it's been an important way for primary care and primary care commissioners to be able to act as a carrot and a stick. So we know what activity you're doing, it's more transparent, and we will fund for this, we won't fund for the other. Clinical leadership and ownership, it's been integral to achieving reform and improved performance. This has come through in other studies that's outside of commissioning that need to engage clinicians as they're the provider of services. And for some work that I was involved in, where the actual barriers were where clinicians had not been involved in some of the early decision making. So it's not just to bring them on at the end when the decision's made, but actually to include them early on in any decision making forum. And it can be hard to do. And if you look at the reform in the UK, the move to local clinical based commissioning rather than primary care based commissioning, there's a subtle difference there, was very much around the evidence trying to engage clinicians into the world of commissioning. Previously they've been sat on the outside of that and impacted by what the commissioners were asking them to do, but weren't really very much in terms of leading that. It was just one or two clinicians. So the idea of clinical focused commissioning was bringing general practice to help shape and inform these decisions. There's been a focus on priority setting tools to support the decision-making process, and there's been lots of this and lots of development around economics and priority setting. There's been a criticism in the literature that's been very much technical, and whilst it's important in early days in commissioning, especially in UK, there was a really limited relationship work, which was equally important. So the whole stakeholder engagement and bringing people along to on this commissioning journey was very limited. It was more on operations and technical aspects. Okay, John, next slide, please. So in terms of the outcome-focused research, well, outcome-focused research tended to be very limited. As I say, the outcomes have tended to be much lighter touch survey, and that's nothing wrong with doing a survey, but it's been lighter touch rather than the more focused using administrative data or patient-reported outcome measures to really look at what difference or not commissioning may have made. And part of this is because it's just so difficult to do this in terms of the commissioning policy. it's really challenging because there's so many confounding variables. It's hard to say that commissioning made that change. Was it the commissioning? Was it the activity-based funding policy? Was it stakeholders in there doing something slightly different than nothing to do with commissioning? Was it partnership, the policy around partnerships? So it's really hard to really focus this on cause and effect. So I think that, and for me, that's why researchers have tended to shy away from that. What has tended to happen, though, is that we've had more small evaluations, as I've said, around more localised commission programmes than the broader commissioning process itself. And as Judith Smith alludes to here, you know, it is a decade of evidence in terms of commissioning, but it's very limited in terms of the impact of the agenda itself. Okay, John, next slide, please. So in terms of impact then, what does this really tell us, and what does the impact tell us? Well, what we've seen in terms of impact is that it's difficult to really measure the broader outcomes. I was involved in a particular study that looked at decommissioning of older people's services, and we did manage to use some patient-reported outcome measures and patient-reported experience measures. It was part of a big study to look at over a 2-year period the impact of the closure of the older people's home and the resettlement of older people into other services. And we managed to do this over the 2-year period to look at the initial onset of the move and how traumatic that was to those individuals, through to later down the line, 2 years' time, when there was very limited impact. In some places, patients or service users actually had improved in terms of their outcomes. So that was a really interesting project that was about the commissioning or decommissioning process, but it was specific to a particular intervention or programme. So in terms of the impact of that and what we learned, well, there was a couple of things that are really important, I think, that came through. One was around making sure you capture baseline, so making sure that you have the baseline evidence and that you can actually use that baseline then to measure going forward. And often the commissioning activity that I've been involved in, people call you in retrospectively and ask you to look at the data they've collected, but they never collected baseline, so you can't see at all how they've travelled. So for this particular piece of research, we were involved early, in fact, ahead of the decision itself, which was really good. What this did was allow for the researchers to really inform and shape the research aspects and to have a greater understanding of the project. The other important bit, I think, for me was having senior researchers who understood some of the ethical challenges in conducting this research. Some of these individuals and participants had dementia, or both the participants, staff, clients, families. It was a very difficult time. So it's understanding some of those sensitivities and having that senior research support, I think, was important. In terms of the impact then, in that particular project, the impact was interesting in that we then got commissioned to do additional work for the UK government and for the Prime Minister's office, where there was actually issues around other services being closed, public sector services. So we developed guidelines. Also, in terms of the impact, we managed to get invited onto NICE's, the National Institute of Health and Clinical Excellence, which is the overseeing body about whether or not things should be prescribed or used within the NHS funding bag. And we were invited to develop national guidelines around disinvestment and investment decisions. So you can see that can have a knock-on effect in terms of what you're involved in, but also in shaping future policy and practice. Going back to the broader commissioning, evidence from research used in government, there has been lots of evidence from research used in other government guidance. The research from the UK has travelled to Australia and is used in their guidance as well as its own. Researchers have been invited to speak on UK House of Commons Select Committee would be one example that I can think of. And this just shows the power that the research can have in terms of influencing the policy process. And the House of Commons Select Committee is really quite prestigious in terms of helping shape government's thinking. So it's quite an important thing for researchers to be involved in. And I think that just shows how you can influence through the sorts of research that we do. More broadly then, in terms of what does all this mean then, and what's happened in terms of the policy itself? Well, in the UK, it's been a frustration of governments about the slow success of commissioning, and that evidence has not been able to demonstrate that commissioning was successful. What that's meant then is there's been successive reforms, so the reforming and reorganisation of the actual commissioning architecture. I can't go into details, but I'm happy to discuss it another time. But what that means for researchers is often when you're partway through your research project, the whole commissioning landscape changes. So the people you are going to speak to are no longer in their employment and things. So the actual policy response can sometimes impact on live research. I think that's it for me, because I'm conscious that we're close to time and there may be some times for questions. Thanks.
Thanks, Suzanne, and thanks everyone for your session. So I've just put one summary slide together just to try and bring all of what we've talked about together. So thinking back to Catherine's presentation, is a really nice illustration of the spectrum of complexity that clinicians, health services researchers can go to in terms of using health services research in practice. And as Catherine's example of a pilot study leading to a greater funding and a more comprehensive study, so you can kind of start small but dream big, and oftentimes you'll get there with good pilot data. In the hospital policy arena, I mean, the big promise has been health systems data, and I think over the last 10 years or so, it really has been improving at a much slower rate than many of us would like. But it is getting better, and access to it is improving. As I mentioned, I think patient-reported outcome measures, everyone accepts it as a good thing, but there are costs associated with collecting these data, and so we really need to work out how they can be best used to improve, in this case, hospital, but more generally, health systems performance. And then in the primary care setting, I think both Jackie and Suzanne really highlighted the challenges of research in that area, particularly around outcome evaluation. And I think that's really because you're searching for smaller effects when you're looking in a primary care setting, and data collection is more challenging. So there's more of a focus on qualitative and narrative research, but it's that balance that's important to look at. How do you combine qualitative and quantitative research in that setting to achieve real impact? But I think, as both Jackie and Suzanne illustrated, it's certainly possible to achieve impact and produce good health services research in that sector. So I think we'll finish there in terms of our presentation. There's a few specific questions. If anyone's got any last minute questions, we have gone a little bit over time, but we're happy to stick around if anyone has questions or issues that they'd like to discuss. So one of the questions Callan Fraser-Bell asked for Catherine around the methods that you used in your qualitative data. You'd like to expand a little bit on that, Catherine?
Yeah, we really just used a thematic analysis where we recorded and coded all the responses from the interview. So we transcribed them all verbatim and coded them into themes and coded everything and brought everything together into various themes around different aspects of what factors influence weighting. I noticed Mark had asked a question previously about reading the whole report of the RCTs. I've got a little list of references for the papers that will describe all of this in more detail if people are interested. I'm not sure what's the easiest way to disseminate that. I can just cut and paste the list into the chat section. I don't know if that will actually work, but or else if people want to contact Sarah, do you want to, John, is that the easiest way?
Yeah, look, we can put the details up on the website next to the recording of the webinar. So this webinar will be put up there, so we can. Yeah. Does that.
I'll just, in the meantime, I'll cut and paste my little list of the few key references into the chat section as well.
Oliver Frank, a colleague of mine here in Adelaide, asked about the expected mortality rates in the analysis of outcomes in New South Wales hospitals in particular, but there's a more general question. So it was the risk standardised mean mortality rate that was estimated. So it's quite a nice way in which they reported it. They showed the impact of controlling or adjusting for different sets of risk factors. So certainly age and gender, but there was a range of other risk factors or comorbidities that they controlled for in that analysis, and we did too in South Australian analysis. And Mark Owusu asked another question around comparing evaluative strategies of hospital services in high-income countries to low- and middle-income countries. And yeah, I think one word we talk a lot about in health services research is context, and certainly, yeah, the context is very different between the health systems in place in high-income and low- and middle-income countries, and so, you know, I guess there are some lessons that can be learned across those different contexts, but you really have to take the health system characteristics and the funding mechanisms into consideration when you're looking at translating or transferring research across countries. So, you know, we've provided a lot of examples today from the UK, but from an Australia and New Zealand perspective, you know, there's certainly significant differences in how care is delivered across those three countries, and so you really still have to take consideration of those factors, even when you're looking across what, on the face of it, look like similar countries. So it's something to be aware of.
Just on that, John, it's Suzanne here. Just thinking about the data that's collected across those countries as well, and it wasn't in developing countries, but I was involved in a European study, and it was really hard to compare just because the way the data is collected, different time frames, the different types of data, and to be able to just do something with that was very complicated. So I think it's like that you say, the contextual, but and the data linked to that context as well.
Yeah, that's right. Okay, well, there's no other questions. Do any of the other speakers have any final comments?
There was just one on the chat room, John, and it was a question around from Snowley. Is there any acute health services that collect patient-reported outcome measures in Australia? I wondered about New South Wales. I think they might be doing that. I know we're starting here in WA at some point, but I don't know if you know of any others.
Patient-reported outcomes. I know that Nick Graves's group in Queensland they've got some pilot work around collecting patient-reported outcomes in cardiology. So I think there's a few pilot studies around, but certainly in terms of mainstream collection, I think it's limited. It's certainly nothing along the lines of what's going on in England.
Yeah, it's not routine, is it?
Not routine yet, but I think it won't be too long before we get there. Yeah. I don't know about New Zealand. Is there any examples in?
No, they're not doing it here. It's not a focus at all. There's patient experience surveys, but not on outcomes.
Yeah. There's a lot of interest. I'm sure it's going to progress, but a lot of research will be going on in that area in the next 5 to 10 years, I think. Okay. Tanya has noted that there's the palliative care outcomes collaboration. So I'm assuming, Tanya, that you're referring to the collection of PROMs through that collaboration. So that's something. Yes. Thanks, Tanya. But yeah, I mean, I think that might be a good subject for a future webinar. It'll be something around patient-reported outcomes, or the state of patient-reported outcomes in Australia and New Zealand. That might be an interesting webinar. And that kind of leads on to the last item, which is really to thank you all for attending, but to ask you for suggestions for further or future webinars that may be of interest to yourselves or colleagues. Because we're always looking for suggestions, we're always looking for potential speakers. So please don't be shy and get in touch with us if you've got any suggestions about topics that may be of interest. So with that, as I've said, thank you, and we'll close it there. And Sarah will be sending around an email with details of the recording and its posting on the website. So. Please keep in touch, and hopefully you enjoyed today's webinar. Thanks, everyone.
Thank you.